To the update on thalassemia, organized by the Sri Lanka College of Paediatricians. We have two eminent speakers today. I hope all of you can hear me.
Yes, ma'am.
Yeah, okay. So thank you for joining with us in this webinar series, which we have been going on since the commencement of the, probably in the last year. So the first speaker we have is Professor Sachith Mettananda, who is a chair professor of pediatrics in the University of Kelaniya, the Department of Paediatrics, and who became a professor at a very young age, and who also has a brilliant academic career. He studied at Royal College, Colombo, and he managed to get through his advanced level exam, securing the second place All Ireland, and he also graduated from the Faculty of Medicine, University of Colombo, securing the second place All Ireland merit. And even in his postgraduate career, he was, I think he was the first who got the gold medal in the MD Pediatrics from the DCH as well. So Sachith is a very young academic, joined the University of Kelaniya at a very young age, and he obtained a PhD, a research degree, in addition to his clinical degree from the very prestigious University of Oxford. And he's also the Commonwealth Scholarship holder who was awarded the Commonwealth Scholarship to continue his studies in United Kingdom. And his special interests in research include thalassemia, and he has, I think, authored many articles in index journals. I think over 100 publications to his name, and many abstracts, many orations, and many presentations, and many talks at prestigious forums. So his curriculum vitae is fairly long. It's very difficult to make a summary out of it. And I know he's a very good speaker and a good orator. So without further ado, I would like to hand the forum over to Professor Sachith Mettananda, Professor of Pediatrics from University of Kelaniya. Over to you, Sachith, to give one of your excellent speeches. We can see your slides.
I hope you can hear me, Amali.
Yeah, we can hear you very clearly.
Thank you very much for that very kind and probably a bit exaggerated introduction. Thank you again. And I would like to thank the College of Pediatricians for giving me this opportunity to talk in this webinar on thalassemia. I must say that I have probably made myself in a bit difficult situation by selecting this topic, which is hemoglobin E beta thalassemia. I wanted to speak on this topic because still a large amount of controversies still remain how best to manage hemoglobin E beta thalassemia and what exactly this disease is. However, I must confess that even today, we don't know exactly how best to manage this disease. The most important message I want to convey is that hemoglobin E beta thalassemia is not equal to thalassemia major. So there's a huge difference between two disease entities. Right. So first of all, before we go into the in-depth management of hemoglobin E beta thalassemia, we need to have a proper understanding of what this disease is. This is a genetic disease, as you all know, and the mutations are in the beta globin gene. Beta globin gene in humans, we know, is located in chromosome number 11. It's exactly the same gene that you have beta thalassemia mutations. So if you have a beta thalassemia mutation, there are about more than 200, some say more than 300 different mutations that can cause thalassemia. what those mutations do is to reduce or most likely abolish the production of beta globin from that particular gene. So if someone is homozygous for beta thalassemia mutations, that individual will not have beta globin. So their beta globin is the main part of the adult hemoglobin A. So they will have minimal hemoglobin A. So that is beta thalassemia. So in hemoglobin E beta thalassemia, it's a state of compound heterozygous mutation. So that means one allele, we all have two beta globin genes in each cell. In one of those genes, in one allele, we have beta thalassemia mutation. So that the beta globin production from that allele is reduced or abolished. So there's no beta globin production from that allele. In the other allele, in the other gene, there is a specific mutation which is known as E beta mutation. This is again a mutation in the beta globin gene. It's a specific point mutation. There's just one mutation in the beta globin gene codon 26. It's in the exon codon 26. There's a point mutation. What that mutation does is that it alters the structure of the normal beta globin. So the beta globin will be produced, but the structure is slightly altered, and we call that beta globin as E beta globin. And this is a functional beta globin which can carry oxygen when it is combined with hemoglobin. However, due to this mutation, the production of this abnormal E beta globin is also reduced. So the E beta globin is produced at a reduced rate. So that is the genetics of hemoglobin E beta thalassemia. If we take this sort of a very brief family tree, patients with hemoglobin E beta thalassemia will have beta thalassemia mutation in one allele and hemoglobin E mutation in the other allele. If you look for the parents, if you do parental screen, one parent will be a thalassemia trait and will carry the thalassemia mutation. And in that parent, the other beta globin is normal. And the other parent will carry the hemoglobin E mutation, which is the mutation that we just described. So if you take a patient with hemoglobin E beta thalassemia from this gene, from this particular gene with the beta thalassemia mutation, there won't be any beta globin produced, normal beta globin. Only the gamma globin will be produced from that chromosome, because the beta globin is completely abolished. Whereas in the E mutation, in the gene that carries the E mutation, there is some amount of beta globin being produced. But that beta globin is a structurally slightly abnormal beta globin, which is known as E beta globin. So when it combines with alpha globin, it forms a specific hemoglobin known as hemoglobin E. So if we look at the hemoglobin subtypes of patients with hemoglobin E beta thalassemia, so they will not have hemoglobin A because they will not have a normal beta globin gene. One gene, beta thalassemia mutation, the other gene, E mutation. So they will not have hemoglobin A, but they will have a special hemoglobin labeled as hemoglobin E, which is a tetramer of 2 alpha and 2 E beta. So that is the highest amount of hemoglobin that they get in this patient. About 57 is hemoglobin E. And from the beta thalassemia mutation, the gene that sort of allele that has beta thalassemia mutation, the gamma globin is expressed. So you have reasonable amount of hemoglobin F synthesized from the other side. So the HPLC or capillary electrophoresis of a hemoglobin E beta thalassemia patient will have high amount of hemoglobin E, high amount of hemoglobin F, and no hemoglobin A. So good thing about this hemoglobin E is that it can carry oxygen and it's a functional hemoglobin. So it's a bit different. It's not really bit, it's quite different to beta thalassemia major, where you will not have a functional hemoglobin. You have only the fetal hemoglobin produced at a lower rate. So the hemoglobin E beta thalassemia is not just a single clinical disease. So everyone will have a genotype. So the genetics will be one allele E mutation, the other allele thalassemia mutation. However, the amount of hemoglobin E produced in individual patient is markedly varying. There's a remarkable variation on the amount of hemoglobin E produced in these patients. Therefore, based on that, they fell into different places in the spectrum, which ranges from very mild asymptomatic hemoglobin E beta thalassemia to very severe transfusion-dependent hemoglobin E beta thalassemia. But if you do the HPLC, they will have exactly the same clinical, same proportion of hemoglobin. If you do the genetics, they have the same mutation. But the E mutation will have a variable amount of hemoglobin E produced, so the severity varies. So the most important thing in the management is to identify which category is this patient belongs to. We have seen patients with very mild hemoglobin E beta thalassemia who maintains a baseline hemoglobin about 7, 8, 9 or even 10 and does not require any transfusion and only diagnosed during adulthood. So mild hemoglobin E beta thalassemia. At the same time, we have patients who start presenting in the infancy, similar to beta thalassemia major. They start presenting with features of severe anemia around 6 months of age and will require transfusion. But a large majority will lie in between. So they will maintain a baseline hemoglobin without transfusion of about 6 to 7 grams per deciliter, but some degree of chronic anemia, which we know as moderate hemoglobin E beta thalassemia. So your management will depend on which group this patient belongs to, whether the patient has transfusion-dependent severe hemoglobin E beta thalassemia, or whether the child has non-transfusion dependent, moderate or mild hemoglobin E beta thalassemia. So how are we to differentiate? How are we to find out which group does this child or the patient belongs to? Which is very, very difficult. I must say, even for me, it's extremely difficult to decide whether the patient is hemoglobin E thalassemia is transfusion dependent or non-transfusion dependent. The best approach that we have found is to observe these patients when they present for about 6 to 12 months without transfusing to decide on which category they belong to. If you start transfusing, you will be trying to maintain a hemoglobin level above 9 so that you will never know whether this child will maintain a baseline hemoglobin without transfusion around 6 to 7 grams per deciliter, which is reasonable. So the best approach is to observe for 6 to 7 months, considering that this child is likely to be non-transfusion dependent hemoglobin E beta thalassemia, and to manage in that way until you are extremely sure that this child requires transfusions and we will not be able to manage this child without transfusion. So the way to see is, if you don't transfuse, if the hemoglobin continues to drop below 7, 6, 5, even 4 every time, that means you cannot manage this child as a non-transfusion dependent thalassemia child. So then you have to probably label and diagnose transfusion-dependent hemoglobin E beta thalassemia and put them on transfusion regime. There are several scoring methods that people have developed, but none have been found very effective. The most commonly used one, even the Thalassemia International Federation recommends this Mahidol scoring system. Mahidol is a university in Thailand, where this study was conducted, where they tried to give a score based on the steady state hemoglobin, age of onset, age of first for transfusion, requirement for transfusion, spleen size, and growth retardation to see whether you can categorize them as mild, moderate, or severe hemoglobin E beta thalassemia, but this has not been very useful. But for example, if a child maintains a pre-transfusion hemoglobin above 7 and presents after about 10 years and has not received a single transfusion up to the age of 10 years, which is not so uncommon in patients with hemoglobin E beta thalassemia. And if the spleen size is small, they can be categorized as mild and they will generally not require transfusion. Whereas if your hemoglobin E beta thalassemia child does not maintain a steady state hemoglobin without transfusion above 6 and presents to you within the first 2 years and required blood transfusions within first 4 years, and the spleen is quite large, more than 10 centimeters, that suggests that this child is likely to be transfusion-dependent hemoglobin E beta thalassemia. But the approach that we take is to keep them without transfusion for 6 to 12 months and see whether they will maintain a steady state hemoglobin around 6 and 7, or maybe even more than 7 without transfusions, so that you can avoid transfusing these patients. Right. So the further management depends on the category that we are dealing. If you are unable to maintain a steady state hemoglobin above 6 and 7, the child requires frequent transfusion, then probably this child needs to be managed as a transfusion-dependent hemoglobin E beta thalassemia. How do we manage? The answer is straightforward. If you diagnose your patient with HBE beta thalassemia is transfusion-dependent, manage exactly same as for transfusion-dependent beta thalassemia major, which you all know that we need to transfuse children with thalassemia major with leukodepleted packed red blood cells, generally 4 weekly, but some will require 3 weekly, some will require 5 weekly. The aim is to maintain a pre-transfusion hemoglobin above 9 to 10, between 9 to 10. And these children will require monthly transfusions, and therefore after about 6 to 10 transfusions, you need to evaluate for iron overload by doing serum ferritin and other markers. And after about 10th transfusion, and when the serum ferritin rises about 1000 nanograms per milliliter, these children should be started on iron chelator medication. Iron chelator choices should be exactly same as for transfusion-dependent beta thalassemia major. And splenectomy is extremely rarely used. If your hemoglobin E beta thalassemia child is transfusion-dependent, they should be offered the hematopoietic stem cell transplantation if suitable donors are available. So I'm not going to talk too much about the management of transfusion-dependent beta thalassemia, which I hope most of you are well aware of. So maintain pre-transfusion hemoglobin 9 to 10, iron chelation same as for thalassemia major. Although we say that severe hemoglobin E beta thalassemia should be managed exactly same as for thalassemia major, in reality that does not happen. We recently conducted this study in 3 main centers, Ragama, Kurunegala and Anuradhapura, and what we found is that patients with thalassemia major, transfusion-dependent thalassemia major, are generally very well managed compared to hemoglobin E beta thalassemia patients who are transfusion-dependent. So the clinicians that, including us actually, for caring for these patients, were not very concerned about maintaining a pre-transfusion above 9 grams per deciliter. And the ultimate result was that these patients have been receiving exactly the same amount of blood that a thalassemia major child has been receiving. However, they have been in a state of chronic anemia. So we have been loading these children with iron as well as not managing the chronic anemia properly. So the key message in managing transfusion-dependent HBE beta thalassemia is to properly manage the chronic anemia, eliminate the signs of extramedullary hemopoiesis, and then take care of iron overload as you would do for a thalassemia major child. So that's the severe transfusion-dependent hemoglobin E beta thalassemia. The real problem is how to manage the mild to moderate non-transfusion-dependent hemoglobin E beta thalassemia. I must say, even today, we don't know how best to manage these children. So they should be managed as non-transfusion-dependent thalassemia. They should not be put on regular transfusion regime. If you put them on, then you can't wait and see whether the hemoglobin will stabilize at a level of 7-8 grams per deciliter, because when it drops below 9, you start transfusing. So they should not be put on a regular transfusion. Each transfusion should be decided individually. So transfusions are generally not decided based on the hemoglobin level. So they are indicated if the child is symptomatic, just there's a need for transfusion. Growth should be monitored in these children very carefully, both height and weight. If there is a growth failure, and if you think it's not been attributed to nutritional causes, and that is probably due to chronic anemia, then again, these children will require transfusion. Severe disfiguring facial features, you might have some facial dysmorphism when you are managing non-transfusion dependent thalassemia, but if they are very severe and deforming, then you probably have to start transfusing. The other indication is rapidly enlarging spleen. However, hemoglobin per se should not be an indication for transfusion unless it is quite low. How low? No one knows. Definitely, if the child maintains a hemoglobin above 7, there's definite no for regular transfusion. If your non-transfusion dependent HB beta thalassemia child maintains a steady state hemoglobin 7, 8, 9, we have several children doing like that. There's no need of transfusion. However, they will have a bit of hepatomegaly, some small splenomegaly, and mild facial changes, which we allow because by doing that, you can avoid iron chelation, iron overload, which is generally the dreaded complication of blood transfusion. So if the hemoglobin is between 6 to 7, yes, still you can wait and individually decide. When it drops below 6, you probably may need to transfuse. These children should be put on given folic acid daily, 1 milligram daily, because their bone marrows are working slightly more than usual and excessively to produce the red blood cells, which are destroyed due to infective erythropoiesis. So non-transfusion dependent thalassemia, transfusions are decided individually and should be started on folic acid. What else can we do? So they should always also be evaluated for iron overload after 6 to 10 blood transfusions, but they may not need, so they may probably get 1, 2, 3 transfusions, or maybe 1 transfusion per year, right? Still, once they reach about 6 transfusions, you need to look for iron overload by doing serum ferritin. Here, the threshold or indication to start iron chelation is serum ferritin more than 800. In non-transfusion dependent thalassemia, the cutoff to start iron chelation is 800. The iron chelator choice, again, same as for transfusion-dependent thalassemia, but in children, we always try to avoid subcutaneous desferrioxamine, but to start deferasirox as the first line. And in these children, iron chelation should be continued until the serum ferritin drops below 300. The other drug that has shown to be effective in patients with non-transfusion-dependent thalassemia is hydroxyurea. It's a very old drug, but recently being evaluated as found to be effective in increasing the hemoglobin in patients with non-transfusion dependent hemoglobin E beta thalassemia. Hydroxyurea is an anti-metabolite drug, so it's an anti-cancer drug actually, but on the other hand, we don't know how it does, but it increases the amount of fetal hemoglobin synthesis. So we know in the beta thalassemia mutation carrying allele, the hemoglobin F is produced. We know the relative amount of hemoglobin F is high in HBE beta thalassemia. By giving him hydroxyurea, you can further increase the absolute amount of hemoglobin F, so that your hemoglobin level also will go up. So it's useful in most patients with non-transfusion dependent hemoglobin E thalassemia. I wouldn't say useful in all patients, but in some or most patients. Hydroxyurea in studies have shown to increase the hemoglobin, induces hemoglobin F, reduce the ineffective erythropoiesis, and it in fact reduces the liver and spleen sizes. But not in all patients, in a subset of patients. The dose of hydroxyurea is 10 to 30 milligrams per kg per day. And everyone whom you start hydroxyurea, you have to evaluate for the response 3 to 6 months after starting, because only a subset, we don't know who will respond, only about 40 to 50% will respond to hydroxyurea. If you find that hydroxyurea has increased the hemoglobin, has reduced the spleen and liver sizes, and reduced the sort of a requirement for transfusions, you always can continue hydroxyurea. However, if the hydroxyurea has not shown any effect subjectively, you may stop a trial of hydroxyurea after 3 to 6 months. We recently did this review as well as the randomized double-blind placebo-controlled trial. This was the first such trial in transfusion-dependent thalassemia. In transfusion-dependent thalassemia, we found that about 40%, and specifically the patients with hemoglobin E beta thalassemia responds to hydroxyurea. But in non-transfusion-dependent thalassemia, the response to hydroxyurea is generally much higher. Once you start on hydroxyurea, you have to educate the patient on the side effects. The common side effects that we have encountered are agranulocytosis. They can develop neutropenia. They can develop thrombocytopenia and sometimes skin rashes. So if the platelet count is less than 100,000, you may have to consider stopping hydroxyurea. So hydroxyurea is one drug that you can always use and see whether this child can be managed off transfusions by elevating the hemoglobin level, particularly non-transfusion dependent hemoglobin E beta thalassemia. So those are the basic things that we generally do. We decide on the transfusions individually. We put them on regular folic acid and we start oral hydroxyurea. Give a trial, 3 to 6 months of trial. If responding, you continue hydroxyurea. If not, you stop. Iron chelation, some may require, some may not, depending on the serum ferritin after the 6th to 10th transfusion. The other option that has been used very often is the splenectomy. Splenectomy has been used often in HBE beta thalassemia patients to increase the hemoglobin. However, the current recommendation is that the splenectomy should be avoided as much as possible, and only absolute indication for splenectomy is hypersplenism. If you have pancytopenia, including thrombocytopenia due to splenomegaly, and if the platelet count is less than 100,000 and cannot be elevated without other means, and if you have excluded all other possible reasons, then the splenectomy is indicated in children with hypersplenism. Massive splenomegaly is a relative indication, but we have generally not done a splenectomy for massive splenomegaly. If you are planning for a splenectomy in a child, you have to make sure that the splenectomy is generally done after the child is older than 5 years. You don't do it unless essential in children less than 5 years, because spleen is of paramount importance to develop immunity against encapsulated organisms. So all children who are planning to undergo splenectomy should be immunized against encapsulated organisms, Streptococcus pneumoniae, Haemophilus, and meningococcus by giving vaccines, appropriate vaccines, preferably 2 weeks prior to the splenectomy. Even if you are unable to do that, doesn't matter, even after the splenectomy, you can vaccinate. All these children should be started on oral penicillin prophylaxis twice daily post-splenectomy. For how long, we still don't know. Some would say for 2 years, some would say for life, but generally we continue for longer periods. The people are going away, sort of moving away from splenectomy, because the splenectomy is known to increase risks, several other risks. It obviously increases the risk of sepsis, And it has also in the adult patients, especially adult non-transfusion dependent thalassemia patients, it has shown to increase the risk of venous thromboembolism, cerebral infarction, pulmonary hypertension, and leg ulcers. Because the morbidity during adulthood is higher, people are reluctant to do splenectomy for thalassemia nowadays. But the absolute indications we have just discussed. So that's the basic management of non-transfusion dependent hemoglobin E beta thalassemia. And we have come to the end of the presentation. The most important take-home messages that I would like you to take is that hemoglobin E beta thalassemia is a different disease entity to beta thalassemia major. It's not the same. I have shown you why it is not. Because of its genetic nature, because the hemoglobin E is produced at a variable amounts, it has a clinical spectrum. The most important thing is to decide on whether the child has mild to moderate non-transfusion dependent hemoglobin E beta thalassemia or severe transfusion dependent thalassemia. If your child has transfusion dependent HBE beta thalassemia, manage exactly as for a thalassemia major. Manage exactly as for a thalassemia major. If the child has non-transfusion dependent HBE beta thalassemia, that means you can maintain his steady state hemoglobin between 6, 7, or 8 without any transfusions, but with some degree of hepatosplenomegaly and facial changes. That patient's transfusion should be decided individually. Those should be given folic acid daily and are candidates for a trial of hydroxyurea. And the final message is that the patients whom you are managing as non-transfusion dependent HBE thalassemia, after some time, after many years, may require more frequent transfusion. Then you may probably have to revise your diagnosis and put them on regular transfusion regimes as for a transfusion dependent thalassemia, which has happened as well. Thank you.
Thank you, Sachith, for that very precise and very to the point presentation. And I'm sure all the listeners would agree that I wasn't exaggerating by any means. So it was, he is one of the best orators that I have listened to, and thalassemia is his bread and butter and cup of tea or whatever you call it. Thank you so much. And I hope we do have an audience from consultants up to medical students. And I'm sure all of you would have had